Acute respiratory distress syndrome is lung damage that comes secondary to a major illness or injury. Something like sepsis, major trauma, COVID, toxic inhalation, really anything that makes you really, really sick. The body responds to major insults with lots of inflammation. This causes capillary vasodilation, and there are 300 million alveoli in the lungs that are all connected to an extensive network of capillaries. The capillaries dilate, and they leak fluid and can cause wet and heavy lungs. However, the thing that really, and I mean really, increases the onset of ARDS is mechanical ventilation, which a lot of your really sick patients and injured patients are going to require. You add positive pressure ventilation to the lung and you are stretching the alveoli. Now, there's already systemic inflammation occurring due to the illness or injury, and you add more alveolar stretch with the ventilation and you can end up injuring the alveoli. The injured and overstretched alveoli becomes compromised and bleeds. And when this occurs 300 million times, that's going to be a huge deal for the patient. The result is ARDS. I like to describe ARDS as trying to ventilate lungs that are like two sponges that are soaked in maple syrup. They're wet, heavy, and the compliance is shit. The result is hypoxemia. ARDS causes an increase in dead space, ventilation perfusion mismatch, and shunt. Imaging will show bilateral ground glass opacities. That tends to be a test question on every certification exam ever. There is no cure for ARDS. They have tried things like steroids and anti-inflammatories and immunoglobulins, but nothing works. It's an uphill battle. You have to keep the patient ventilated and oxygenated until both the lungs can heal and the patient can be healed from whatever malady they suffered in the first place. Typically, these patients require ventilation with higher pressures and lower tidal volumes to try and minimize alveolar stretch. Mortality is very high. The key is to try and avoid ARDS if you can, and you do this by employing an ARDS-net ventilation strategy to prevent the ventilator-acquired lung injury. ARDS-net was a huge study, and they recommend that you start with lower and safer tidal volumes if you are using a volume ventilation strategy, which, let's face it, most emergency departments use on the freshly intubated patient. So you take the patient's ideal body weight, not the total body weight, and you use a chart to determine ideal body weight based on the patient's sex and height. And then you initiate ventilation at 4 to 8 mLs per kilo of ideal body weight. Remember, if the ventilated patient becomes hypoxic and it's not a stupid simple fix like a connection popped off of the vent circuit, or the patient is desynchronous with the ventilator because they are uncomfortable, always increase PEEP first to try to correct hypoxia. Do not start increasing the tidal volume. PEEP first, then FiO2.